So as Pam mentioned, I'll be talking about pharmacogenomics and cardiac toxicities of tyrosine kinase inhibitors as a whole, and specifically the tyrosine kinase inhibitors that inhibit the VEGF receptor. So I have no financial relationships to disclose. I do want to disclose that I'm not like a clinician. I don't practice clinically. I don't have clinical pharmacogenomics training, and actually no one on my team does. But we are fortunate to work really closely with the health system here, and particularly with the tumor board, which is where this patient came from. And so we have opportunities to sort of contribute some of our research insights into clinical care. And also, since I'm not a clinician, I really appreciate the insights from the people on this call because we have our opinions on this case, but it'd be really nice to, get a consensus from a group of seasoned clinicians. And so look forward to discussing the case. So sort of jumping into some of the didactic slides. So first I'll talk about the mechanism and use of anti-VEGF TKIs. So VEGF is a signaling protein that stimulates vasculogenesis, which is the formation of the vascular network, and angiogenesis, which is the process by which new blood vessels grow from existing ones. And VEGF signaling, not surprisingly, is upregulated in cancer due to the hypoxic stimuli of rapidly proliferating tumors. And therefore, VEGF signaling is necessary for the maintenance of supply of oxygen and other nutrients in a variety of solid cancers. It's been implicated in lung, breast, colorectal, and genitourinary cancers like kidney cancer that we'll talk about today. So accordingly, VEGF inhibition is a therapeutic strategy that has demonstrated durable efficacy in various of these solid cancers, including renal cell carcinoma. And anti-VEGF receptor TKIs, consisting of the ones that are listed on the screen here, are first-line agents, either as monotherapy or in combination with immune checkpoint inhibitors for both clear cell and non-clear cell renal cell carcinoma histologies by the National Comprehensive Cancer Network and other leading cancer guidelines around the world. So a bit about the epidemiology and mechanism of cardiomyopathy during anti-VEGF receptor TKI therapy. So anti-VEGF receptor TKIs are associated with common and less severe adverse drug reactions, things like gastrointestinal disturbances and dermatological reactions, and also with more severe and commonly treatment-limiting adverse events like hypertension, which occurs in about 15% of patients, hepatotoxicity, which occurs in about 10 to 20%. And actually, we have another case at IU where we had a patient who was a dual CYP3A4 and 5 poor metabolizer who had pretty bad hepatotoxicity with axitinib, one of these drugs that we think was probably attributable to their genotype. And then these also cause hematologic and thromboembolic disorders, and finally cardiomyopathy, which occurs in about 10 to 20% of patients. So this waterfall plot on the right is taken from an analysis from one of the landmark phase 1/2 trials, where 36 patients, so there's 36 little bars, like column bars here, were treated for GI stromal tumors with 50 milligrams sunitinib, which is the approved dose for most indications, including renal cell carcinoma, for 4 cycles. And as you can see, 7 patients, or about 19% of the population, had reductions in their left ventricular ejection fraction, which is the clinical parameter that they use to assess systolic function. And they defined this drop greater than 15% as clinically relevant, the investigators in the study did. And then even, so that's about, these sort of 7. And then 2 patients had really profound drops in LVEF that produced severe heart failure symptoms. And of note, all the patients with reduced LVEF in this study exhibited some degree of recovery when the drug was discontinued. And these 2 in particular, and some of the other ones, were treated with some of the heart failure medications like beta blockers and RAS pathway agents. And actually, some of these even tolerated eventual rechallenge with sunitinib, which I think is interesting, will become relevant when we talk about the case. So the mechanism of cardiomyopathy with sunitinib and other anti-VEGF receptor TKIs is believed to be multifactorial and to result from both direct inhibition of the VEGF receptor, which has a naturally cardioprotective role, and from the inhibition of some of the other tyrosine kinases that these molecules hit. So things I mentioned here, like the ribosomal 6 or S6 kinase, and then the adenosine monophosphate activated protein kinase. And so next I want to talk about the metabolism of sunitinib, axitinib, and most of the other anti-VEGF receptor TKIs. And so they involve CYP3A. And so you can see on this, in the top right, on this figure that was taken from ClinPGx, that, sunitinib is predominantly metabolized in hepatocytes by CYP3A4 and CYP3A5, and to a lesser extent, some of the CYP1A enzymes. And accordingly, the FDA labels for all of the anti-VEGF receptor TKIs, except for lenvatinib, recommend against concomitant administration with strong CYP3A inhibitors or inducers. This is actually taken from the axitinib drug label, and you can see, during co-administration with ketoconazole, which is a strong CYP3A inhibitor, the AUC geometric mean ratio, so the difference in AUC, the ratio of the AUC when it's given in monotherapy versus when it's given with ketoconazole, increases over 2. And then sort of a similar but opposite story with rifampin, which is a strong CYP3A inducer, in addition to lots of other phase 1 and phase 2 enzymes that it induces. But you can see the AUC ratio is decreasing like about 8-fold to 12% here. And so in addition, sunitinib and pazopanib are substrates of efflux transporters like ABCB1 or PGP, which is shown in the ClinPGx pathway diagram, and also ABCG2, which we call BCRP, or the breast cancer resistance protein, and PGP, or P-glycoprotein. And then from the diagram, all of the CYP-mediated anti-VEGF receptor TKIs are inducible by transcription factors like PXR and CAR, which are these NR1I2 and NR1I3. It's the gene names for PXR and CAR, respectively. And so this is really relevant to this case, but when looking at potential genetic variants that might have predisposed this patient or any patient to cardiomyopathy from these TKIs, we thought about both pharmacokinetic and pharmacodynamic related genes. And so the pharmacokinetic related genes, I largely introduced in the last slide. You'll see a few other ones on here, and like CXCL8 and this SLCA22A5 transporter. And these were added because ClinPGx has some significant studies that demonstrated that these were involved with either one of these TKI efficacy or toxicity. And so we added them to our candidate gene list. And then for pharmacodynamics, we were really interested in familial cardiomyopathy syndrome genes, known genes that are pathogenic and causative of these different phenotypes. And this is all kind of stemming from research in the past 10 years that shows that patients, even if they're not homozygous for these variants, but they carry them, they might not have any symptomatic cardiomyopathy or cardiomyopathy symptoms at baseline, but they do have an increased risk for cardiomyopathy during treatment with drugs that can also, through a separate mechanism, cause cardiomyopathy. And so two of the genes that I think are important to mention here, one is myopalladin, which will be more relevant to the patient case, and the other one is titin, which is really emerged as a strong predictor for anthracycline-induced cardiomyopathy. And so another topic I want to mention is that at IU School of Medicine, we maintain IRB-approved protocols that allow us to investigate exceptional drug responses. And this allows us to make some pharmacogenomics discoveries, as I hope I'll illustrate with this case. And so we have 2 standing IRB protocols that allow us to enroll patients who experience these exceptional responses, either efficacy or toxicity. And so the protocol that I show on the top here, just called the RADAR protocol, is so Emma Tillman is the principal investigator of this protocol, and this allows us to prospectively collect blood samples on which to perform genomic testing, which typically is our research grade whole genome sequencing that we do. And then this bottom protocol is our repurposing protocol, for which Todd Score is the principal investigator. And this allows us to utilize the paired somatic germline whole genome sequencing that is generated during our standard oncology precision genomics clinic workflow. And we can repurpose this for pharmacogenomic analysis. And in either protocol, we're able to clinically validate variants that we identify from this sequencing within our clinical lab, either using our CLIA validated PGx panel, or if it's a rare variant that's not on our panel, our lab can perform specific assays like TACMAN or Sanger to clinically validate the existence of these variants that we think might be associated with some of these exceptional drug responses. And so this is kind of a schematic that describes how we are developing workflows to return pharmacogenomic results. This is specific to our solid cancer tumor board population. And so here, starting up here, blood and tissue samples are sent to a commercial lab. Right now, we're using Caris Biosciences for paired somatic germline whole exome or whole genome sequencing. And then these sequencing files are returned to IU Health. We partner with a local biotechnology company that's called Fountain Life. Actually now not Liphomic, but that was our previous name. And then the sort of the somatic analysis, which is done by Caris, sort of filters through the clinical teams. And then we can take that germline, those germline results, use computational tools. We use this tool called ALDI to extract the pharmacogenomic diplotypes. And ideally, we want to return these clinically. But right now, since our testing is done at Caris, the directors of our pharmacogenomics laboratory aren't able to sign off on these because they don't know if the platform is changing. So what we do now is we actually will just take these results to tumor board, and in the clinical discussion, we'll say, oh, by the way, this patient is heterozygous for a loss of function DPYD variant. So if you're thinking of starting a fluoropyrimidine, you should use potentially a reduced dose. And we don't tell them to act on these preliminary results. We say, what you should do is order our clinically valid PGx panel that covers these variants. And then, if it comes back that they're truly heterozygous for this, I mean, we've done our own research, and our extraction method, this ALDI method, is about 99.5% accurate. So we feel pretty good that what we say is there. But, we really want to have a clinically valid test before we make any sort of strong recommendation, or before our clinician would make a decision based on those. And so currently, we're not putting these results into the EHR, the electronic health record, because they're not clinically valid. But we are developing our own institutional next generation sequencing lab. And eventually, the plan is to send the blood samples there to do the germline sequencing. And then our laboratory directors will be able to validate the variants. And so then, we want to incorporate it directly into patient care. The next topic I want to talk about is the Naranjo criteria that are used to assess causality for putative adverse drug reactions. And so these criteria were developed at the University of Toronto in 1991. And so they're particularly for use in controlled trials during drug development, which is why some of these questions don't seem incredibly relevant for clinical practice. Like there's one about a placebo. Let me find it. Yeah, number 6, did the reaction reappear when a placebo was given? Well, that's not something we typically do in clinical practice, but lots of people have adapted this scale for determination of whether adverse drug reactions are truly drug related in clinical practice, and I think it's suited pretty well for that. So it consists of 10 questions, which you see on the left side here, and you add up based on your answer to this, and you tabulate an overall score. But based on that overall score, you can interpret, the level of causality as doubtful to definite. And rather than go through this now, we'll go through this with a patient case, and I think it'll better illustrate sort of how you use this tool, and yeah, you can assess whether you think it's useful. A final point that I want to stress is that although rare variants, and here we're really describing variants that have an allele frequency less than 1%. And so while they're individually rare, essentially every patient carries some rare variant that has potential clinical implications. And so analysis from about 2,500 patients in the 1,000 Genomes Project found that individuals carried between 76 and 190 rare non-synonymous germline variants that were predicted to have they're predicted to be deleterious, and up to 20 that are predicted to have associations with potential diseases. And so while any one variant is rare, the genome is vast. We have about 30 million protein coding nucleotides, and not to mention the potential for regulatory variants. So we all essentially carry deleterious rare variants. And I think that underscores the importance of why methodologies to study rare variants are important.